About class 3 malocclusion. In this lecture, we're going to discuss the definition, etiologies, and features together with the management of class 3 malocclusion. Starting with the definition, when we say class 3 incisor relationship, we mean that the lower incisal edge occlude anterior to the cingulum plateau of the upper incisors. However, this can be as reversed overjet, as we can see here. It also can be as an edge to edge, as we can see in this one, and also it can come with a positive overjet, as long as the lower incisal edge is occluding anterior to the cingulum plateau. Here's the cingulum plateau of the upper central incisor. Here's the lower incisor sitting anterior to the cingulum plateau of the upper incisors. Don't forget that this classification is according to the British Standard Institute. Now, what about the etiology of this malocclusion? As we discussed in the previous lectures, we always look at the skeletal, soft tissue, and dental factors. Starting with the skeletal, we as well divide them into three dimensions: anteroposterior, vertical, and transverse. Starting with the anteroposterior relationship. Usually, patients with a class 3 malocclusion, we expect them to have a class 3 skeletal relationship. That's kind of causing the class 3 dental relationship. And usually, the cause for this class 3 skeletal is the prognathic mandible, where the mandible is sitting ahead of the zero meridian line. If we drop a zero meridian line here, we can see that the chin is sitting anterior to this line. Also, it could be both or hypoplastic maxilla. I mean, when you have a class 3 skeletal, it's either the mandible that is protruded or the maxilla is sitting back, it's retruded. So if we look at this patient here, we need to diagnose how we can know about the retrognathic maxilla. Don't forget that the maxilla is a big bone. It has multiple processes. In this diagram here, this is represent the maxilla. First, we have the alveolar process, then we have the zygomatic process of the maxilla, and we have the infraorbital process of the maxilla. So if the patient has a class 3 due to retrognathic maxilla, when the maxilla goes back, everything else with it would go back. Also the infraorbital rim and the zygomatic process. So we can see that those patients, they don't have zygoma, they don't have infraorbital rim. So if you compare these two patients, you can see here that this patient has a prominent cheek, while this one, he has a flat cheek. We call this malar hypoplasia, where we don't have the zygoma. And also because the area next to the nose will be flat, we call it paranasal hollowing. If you look from underneath the patient, you can see straight to his eye, because here there's no infraorbital rim. It's a pure flat surface. And usually those patients, like in this case, this patient has a retrognathic maxilla and prognathic mandible. It could be only maxilla. If you can look at this patient, she has mandible in the right position if you drop the zero meridian line. However, if you look at the maxilla, you can see the signs of the paranasal hollowing, not as severe as the previous patient, and the infraorbital rim, infraorbital margin, is kind of retruded as well. So you can see that it has here a flat surface. Patient has a class 3 here due to retrognathic maxilla. So why do we have prognathic mandible? That's a very good question. Prognathic mandible has a strong association with genetics. How do you know that? From the Habsburg family. This is family used to rule Europe for a quite long time, and they used to marry from each other. So all the genetic disorder or genetic features become condensed and obvious. And you can see that all the family has a prognathic mandible. So genetics has a strong class 3 due to prognathic mandible has a strong genetic inheritance pattern. Does that mean that class 3 incisor relationship happen only or occur only in a patient with a class 3 skeletal? The answer for this question is no. Because most of the patients with a class 3 incisors will have a class 3 skeletal, but not all of them. For example, you can have a class 1 incisors with a class 2 skeletal, with a class 3, you can have a class 1 skeletal, but the incisors are a class 3. Maybe due to a local factor, the upper incisors are retroclined, or maybe because of the displacement. Also, class 2 patient can have a class 3 incisors. Maybe due to the displacement. For example, in the maxilla, you have a hypodontia, missing laterals, teeth are retruded, resulted in a class 3. So yeah, it's unlikely and it's not quite often to see class 3 incisor relationship in a patient with a class 2 skeletal. However, it's possible. If you look at this patient here, she has a kind of retruded mandible. She's mild class 2. I will accept if you say class 1 as well. But when you look at her incisors, you can see that she's a class 3 incisor relationship. But this class 3 is purely due to local factor where the upper incisors are retruded. And when the patient has a class 3 incisors or a crossbite with displacement, some authors they say this is a pseudo class 3, which means it's not really class 3, it's just class 3 because of the displacement. So that was about the anterior-posterior relationship. Now what about the vertical relationship? Okay, for the vertical relationship, let's look at the mandible. Patient can have either downward and backward rotation, as we can see in this X-ray, or the opposite, upward and forward. If a patient has a downward and backward rotation, it means that the mandible will go downward and backward, which will reduce the severity of the class 3. Which in contrast, if the patient has an anterior growth rotation, the mandible will go forward and upward, making the class 3 look more worse. So you will think that we prefer patient with posterior growth rotation because that will reduce the severity of the malocclusion. But the answer to this question is no. We prefer patient with anterior growth rotation. Why is that? Patient with a posterior growth rotation, they usually have either reduced overbite or open bite, as we can see here. While patient with anterior growth rotation, usually they will have a deep overbite. Deep overbite is important for correction, for stability of the class 3 correction. So, if we broke-line the incisors here in this photograph to correct the crossbite, and then the relapse will happen by the upper incisors being retroclined, the lower incisors will stop them because we have a positive overbite. While here, when we have an open bite, the upper incisors can go back to where they started normally without any problem. Then we have to look at the transverse relationship. Whenever we study malocclusion in the previous lecture, we said that it's unlikely to have asymmetry with a class 2 division 2. However, because the class 3 etiology is the overgrowth of the mandible, increasing the growth of the mandible, then you do expect that this growth could be abnormal, resulting in asymmetry on the mandible, as we can see in this photograph. So out of the malocclusion class 1, class 2 division 1, class 2 division 2, class 3 has the most common to see a skeletal asymmetry with that one. As you can see in this patient, the chin is deviated to the left side of the patient. Now we are done with the skeletal relationship. We're going to talk about the soft tissue relationship. Now, if you look at this patient here, you can see that the upper incisors are proclined while the lower incisors are retroclined, which we call it dentoalveolar compensation. Now, which component or which part of the face helped the lower incisor to be retroclined? The answer is the lower lip. Which part helped the upper incisor to be proclined? The answer is the tongue. So here, the soft tissue in a class 3 malocclusion, they are trying to mask the severity of the malocclusion. They are working with us. They are helping to camouflage the class 3 skeletal relationship. The only exception is the patient with the tongue thrust, in which they achieve the anterior oral seal by protruding the tongue to touching the lower lip and resting between the upper and lower incisors, which will cause proclination of the lower incisors and anterior open bite. Now, what about the local and the dental factors? Now, usually when you have a patient with a class 3 skeletal, the dentition will try to compensate for that. So if you have a class 3 now, the lower incisors will tend to go retroclined in order to reduce the overjet, while the upper incisors will try to procline to reduce the overjet as well. So usually, if this is the lateral cave for the patient, usually with a class 3 malocclusion or class 3 skeletal, upper incisors will be proclined. As you can see here in this patient, it's 120. While the lower incisors, they tend to be retroclined to compensate for the skeletal relationship. Now, because the maxilla usually is retruded or hypoplastic, which means smaller, and the mandible protruded and prognathic, which mean usually bigger, so usually we either have a well-aligned or spaced lower arch, and the upper arch usually mild to moderate or severe crowding, even like this case. It depends on the retrognathia. So generally speaking, in a class 3 cases, you will see a well-aligned lower arch and crowded upper arch. Crossbite. As we said, by definition, usually we have an anterior crossbite. We could have an anterior crossbite when we discuss class 3 malocclusion. But the thing is, it's usually as well common to find posterior crossbite or generalized crossbite, as we can see here. And why is that? Simply because we have an AB discrepancy between the maxilla and mandible. Let me explain this to you. The black color here in this photograph represents the maxilla, while the purple color or the pink color represents the mandible. As you can see that the mandible is almost triangular in shape, with the widest part being posteriorly. If the patient has a class 3, then the mandible, it means that the mandible is in a more forward position in relation to the maxilla, which means that you are moving the wider part of the mandible forward to occlude with the narrower part of the maxilla, because as well the maxilla is wider posteriorly compared to anteriorly. So anteriorly it will be narrower, but you are pushing the mandible, which is wider now, to occlude with that one. So we're going to have a crossbite. If you look at this photograph, all what we did, or what the author did in this diagram, is just moving the mandible forward without changing any of the dimension in the transverse dimension. So what happened, because you are moving, now if you look at this photograph, in the canine is biting with the canine, while here the canine is biting with the premolar. So you're moving the wider part of the mandible forward. So how are we going to manage class 3 malocclusion? We usually have 4 treatment options. We have accept, we have camouflage, growth modification, camouflage. Last one is orthographic surgery. However, in a class 3 malocclusion, we have one more option called treatment in the upper arch only. And we're going to see now why we're going to do this. Starting with acceptance as an option, we mentioned that in the previous lecture. We can accept as long as there's no functional problem. There's no problem that will result in a damaging effect in the future for the patient if we don't do treatment. So for example, if you have a patient like this who has a massive anterior open bite, class 3 skeletal relationship, but he's happy, he's eating properly, and he doesn't care basically. So do we have to send him for treatment? Well, the answer, it depends on the displacement. If we have displacement, that means that there's a functional problem that it has to be corrected. But if there's no displacement, then the answer is no need for treatment. And that's what happened for this patient. Just to remind you about the displacement, when the patient is biting, he's biting edge to edge. He's not feeling comfortable, so he's sliding the mandible forward. This sliding of the mandible forward, it could affect the TMG in the future. As you can see here, when the patient, that's how we're posturing the mandible forward. So the question is, if you get a patient with a class 3 incisor relationship, with a crossbite, and associated with displacement, can we wait? The answer is no. Immediate treatment is necessary, even if the patient is not in the full permanent dentition, which means that we're going to conduct an interceptive orthodontics for this patient. So why do we have to provide the treatment then? Because simply if you look at the crossbite, usually the patient bite edge to edge and then slide the mandible forward. This sliding will cause attrition to the labial surface of the upper central incisors. And also, every time it's pushing the lower incisors forward, that will cause proclination and maybe gum recession to the lower incisors. Displacements mean that the condyle is outside of the fossa all the time when the patient is closing, which also can, in theory, and it has a weak evidence, causing a TMD in the future. So whenever we see a patient with a crossbite with displacement, whether he's young or a child or an adolescent or an adult, treatment has to be conducted immediately. If you have an example like this patient, she has class 1 incisor relationship, but this lateral incisor in the class 3 position where it's associated with displacement, crossbite with displacement. Now we don't provide treatment at this age now, full comprehensive treatment, because we need to wait for all the permanent dentition to erupt. However, we can do an interceptive treatment which we only fix this lateral incisor. And that's what happened exactly. We just corrected the lateral incisor crossbite. Then the second option for a class 3 treatment is growth modification. First option is chin cup. Chin cup was used in the past, and it is for whole philosophy or the whole idea that you're applying a heavy force directed to the condyle. And they found that this would kind of reduce the growth of the mandible only on animal studies. The theory behind that when you are directing the force toward the condyle, don't forget that the condyle has a cartilage that is responsible for the growth of the mandible. So if you direct the force, a heavy force, to the condyle where the cartilage is, you're limiting the ability for the cartilage to expand. However, unfortunately, a lot of studies has been done on the chin cup, but they found that yes, initially you get reduction in the growth of the mandible and improvement of the class 3 skeletal. However, it's all reversed when the patient stops wearing the appliance. So do we recommend chin cup anymore? From the evidence, the answer is no, because it doesn't work. It does not really improve the class 3 skeletal. So we'll go now as if chin cup is not working. What about reverse twin block or a reverse twin block appliance. So you can see in this photograph here, that's a twin block using for a class 2, in which the mandible is postured forward. While this one is the reverse twin block, where the mandible is positioned posteriorly. Now you just need to know that positioning the mandible posteriorly is not an easy job to be done, because we have the retrodiscal tissue, which is highly innervated and can cause like pain for the patient. Then we have Frankel 3. The idea of the Frankel appliance, as we covered in the functional appliance lecture, that these are the only tissue bone, which means they have no contact with the teeth. How they work, they simply manipulate the soft tissue. So in the class 3 patient here, you want the upper incisors to be proclined. So what they do, they take the effect of the upper lip, so the upper incisors can procline freely. While in the lower arch, you just have a labial bone that will help to retrocline the incisors. Frankel 3 appliance, or even 2-1, all of them are bulky appliances, and they are not really used anymore at these days. That will take us to the last orthopedic or functional appliance, which is called the reverse ball headgear. The whole idea of the reverse ball headgear, it pulls the teeth out. So the whole theory behind it, you get support from the forehead, you get support from the chin, and then you run elastics to the teeth. So the idea that you are using it in the correct time, so you pull the teeth and the bone with it, so you get mostly dental skeletal camouflage. That's again in theory. All right. So let's now understand what are the effects of this face mask. So it takes support from the forehead, from the chin, and then pulling the incisors forward. So it will cause proclination of the upper incisors. It will cause prognathism of the maxilla, because you are dragging the maxilla. While in the lower arch, you get support in the lower chin, which will make the patient to open her mouth or open his mouth because of this support. So the patient will be more again into mouth breathing. All right. Now, when the patient has this mandible going downward and backward, that will affect the vertical relationship. So the patient will have an increased lower facial height after the treatment. Overbite will be reduced after the treatment. So if we're going to think now about the effects so far of the face mask, it will cause retroclination of the lower incisor, proclination of the upper incisor, downward and backward rotation of the mandible. What about the maxilla? Yeah, well, evidence found that in 20% of the cases, it will move the maxilla forward. Again, in variation with the patients. As you can see, the patient has now opened the bite because of the downward and backward rotation of the mandible. So if we're going to now decide what are the features for the patient, number one, we will say that the maxilla is hypoplastic because it's going to move the maxilla forward. However, does that mean that any case with a hypoplastic maxilla can be treated? No, the answer is no. It should be mild skeletal discrepancy. Lower facial height should be reduced because we're going to go downward and backward rotation. Upper incisors are average because most of the effect is dentoalveolar. So what's going to happen is proclination of the upper and retroclination of the lower. So that means we need to have them at the beginning, for the example, the upper to be average or at least retroclined, or at least average, so that when we procline, the incisors will not end up with excessively proclined incisors. A normal to prognathic mandible, because the mandible, if it's severely prognathism, it will not be corrected by the face mask. We know that the face mask do a downward backward rotation. Now the question is, when do we use it? Now, as you can see here on the slide, it's 8 to 10 years of age. Now, why 8 till 10? We should use it, not 11 to 13, as we do with a functional appliance, twin appliance for a class 2. The reason, because of the growth spurt of the maxilla and mandible are different. Usually, this is a common scare. Usually, mandible is closer to the general growth, which is the growth of the height, the general growth of the body, which the growth spurt happened between the age of 11 to 13. While the maxilla is closer to the neural growth, in which the growth will finish by the age of 7. However, the maxilla is still growing until the age of 10. So the growth spurt of the maxilla is 8 to 10, while the growth spurt of the mandible is 11 to 13. So then we finished 2 options. Now we'll go to the third option of treatment, which is camouflage. So to decide if the patient camouflageable or not, you have to answer yourself a couple of questions. Question number 1, is the patient profile is the main concern or not? If the patient's concern is the profile, then orthognathic surgery is the only option for him that will fix the profile issue. If the profile is not an issue, then he just need to look at the occlusion. What we need to do to fix his teeth, we need to look at the occlusion and see whether or not we can achieve this goal. of achieving class 1 incisor relationship, for example. So let's go through the cases and you will see exactly what I'm talking about. Starting with this patient, she has a reversed overjet. Well, we decided to do upper arch treatment only because she has a well-aligned lower arch. And what we did is we decided to start by correction of the overbite with the class 3 by proclination of the upper incisors. And we went to using removable appliance because we want the advantage of the posterior bite plane, because patient was breaking the glass inomer that we placed. So we placed a removable appliance with posterior bite plane that will help to correct the crossbite. You notice now the crossbite is corrected, but then we need multiple tooth movement to fix the canine and the incisors. So fix appliance stage and then we are done. So that's kind of simple class 3 cases where you end up with a class 1. Class 3 is class 1 incisors, canine, canine relationship. Now some cases in which he has a class 3 and this class 3 is associated with crowding. And here we tend to do extraction because we need to create space to align the teeth. However, the extraction pattern in a class 3 patient usually goes with the upper 4s and lower 5s because you don't want to do an excessive retraction of the lower incisors. This is the patient during the treatment and this is toward the end. Another case in which you can see that the patient has a class 3 relationship, retrognathic maxilla, and also what is important that she has a missing lower right 5. So what we did is we extracted the 5 on the opposite side. So we only extracted 2 units and then class 3 correction. If you have a patient like this who is 13 years of age, she's complaining that she doesn't like her teeth. Her dad is coming to the clinic with her and her dad is 2 meters high with prognathic mandible. So that means that it runs through the family. There is genetic inheritance in this class 3 and now we can't provide treatment because we need to wait until the growth is finished and we make sure that the treatment that we're conducting is not going to be relapsed. So how to do this? Simply you can offer the patient a comprehensive treatment or just a treatment in the upper arch in which you align the teeth to make them straight. So the patient will be happy and you're waiting until the final growth to happen. So if you look at this patient, this is the amount of crowding and this is here after the correction of the crowding without bonding the lower arch with only upper arch treatment. The last option is orthognathic surgery. When the patient has a severe malocclusion that is severe enough that we can't camouflage it, or the patient has a complaint about her profile, then the only option is surgery. As you can see with this patient, she went for orthodontic preparation and then maxillary advancement and mandibular setback. So the overjet and overbite is everything is correct, as you can see here in this photograph. Now retention. The most important factor for retention is achieving a positive overbite. So for example, if you retract the lower incisors to correct the class 3 incisor relationship, as you can see in this diagram, now when the lower incisor or the upper try to move against each other, they will stop from each other. They were preventing them. So for example, in this photograph or this video, the upper incisors are trying to move backward, but the lower incisors, because of the deep bite, they stopped it. So if you have an open bite like you see here, the lower incisor will be retracted without any stop, so the retention will be compromised. And thank you very much for listening.